Good afternoon, everyone. Today I am going to talk about autocoids. In the autocoids, I am going to discuss only about the histamine. Okay, histamine. So, what do you know about histamine? Histamine, it is synthesized from the histidine. Okay, histidine, and histamine is stored in the granules of your mast cells. The mast cells, which is responsible for your asthma, anaphylaxis reactions, and all allergy kind of reactions. It is because of your mast cells, and histamine acts mainly on histamine receptors. We have H1 and H2 receptors. Recently, they have found H3, that is presynaptic, is found to be presynaptic, and H4 receptors have also been isolated. Totally, we have H1, H2, H3, H4. And histamine can cause your dilatation of the blood vessels and can result in flushing and hypotension. Okay, so in anaphylaxis, you will get anaphylactic shock, and there is result in hypotension. That is because of release of histamine from your mast cells. That you know that histamine is stored in your granules of the mast cells. So during anaphylaxis, it is get released from the mast cells and can cause your dilatation of the blood vessels and causing hypotension and flushing. So there will be vasodilation. There will be more blood flow on that area. It leads to flushing on that area. And so therefore, because of the hypotension, there will be a fall in blood pressure that is mediated by both H1 and H2. H1 is affected earlier by the release of nitric oxide. Nitric oxide is a potent vasodilator, and H2, it is delayed and persistent. It is delayed and persistent, and because of the direct action on the smooth muscles of the blood vessels. So falling the blood pressure is carried by H1 because of early release of NO, and caused by H2, and the H2 is delayed and persistent by direct action on your smooth muscles of the blood vessels. And mainly histamine can cause edema because of increased capillary permeability, and results in edema because of the stimulation of the H1 receptors. So any histamine agonist, they can cause edema by causing increased capillary permeability. And normally we have to know the triple response of histamine. So intradermal injection of histamine can lead to triple response. What are these triple response? That is red, wheal, and flare. And red is due to vasodilation. Okay, because of vasodilation, there will be red reaction. And wheal is due to exudation of the fluid, edema. Due to increased capillary permeability, there will be a wheal. And flare, it is because of your the the redness will spread because of axon reflex. So these are the triple response of the histamine. It is because of the H1 response, mainly because of the H1 response. So intradermal of injection mean histamine can cause triple response. First, there is red reaction because of vasodilation, and wheal due to exudation of the fluid because of increased capillary permeability, and flare because of the spreading redness due to axon reflex. It is primarily at H1 response. And H1 receptor can stimulation. Okay, H1 receptor stimulation can cause your negative dromotropic effects. There is decreased AV conduction effect because the cardiac conduction will be delayed. Okay, so it can cause negative dromotropic effect, decreased conduction effect in the heart. H1 receptor, and H2 increases your force of contraction of the heart, of the isolated heart. Okay, but its effect on the intact heart is not prominent. So H2 causes increase in the force of contraction of your isolated heart, not your intact heart. Intact heart, it is not prominent. So histamine, it is a powerful contractor of visceral smooth muscles, a smooth muscle constrictor through H1 receptors. So it can cause your smooth muscle contraction all over the body. It can cause bronchoconstriction. It can cause abdominal cramps by stimulating the smooth muscles of abdomen. It can cause abdominal cramps and bronchoconstriction. And it can H2 receptors, you know that it can stimulate your gastric acid secretion by stimulation of the H2 receptors, because H2 receptors are present in your proton pump. And it can cause pruritus and itching and pain because it can stimulate your nerve endings also. It can cause pruritus and pain. And mainly histamine, it will stimulate your reticular activating system, so it will maintain your wakefulness throughout H1 receptors. So histamine stimulates your reticular activating system. It maintains wakefulness through H1 receptors. And H3 receptors, we talk about H3 receptors, they are pre-synaptic in location. So whatever agonist of H3 receptors, they will inhibit the release of histamine. That is the property of pre-synaptic. So if you act on H3 receptors, anything in the pre-synaptic, it will inhibit the release of histamine. So if you are giving inverse agonist or antagonist, then will lead to opposite reaction. That is, increased histamine will be released, leading to wakefulness, because we know that histamine is stimulator of reticular activating system. So it can increase your wakefulness. And pitolisant, we have, it is an inverse agonist of H3 receptors. So it can increase your histamine, it can increase your wakefulness. So it is a drug approved for your ADHD and narcolepsy, where you feel people feel very sleepy always. So to improve the wakefulness in such patients, you have to give inverse agonist, H3 inverse agonist, which will increase the histamine, which will increase the wakefulness by stimulating the reticular activating system. So we have the compound called tiprolisant, approved for your ADHD and narcolepsy. ADHD is attentive deficit hyperactivity disorder. And H4 receptors are present in your mainly in your hematopoietic cells like eosinophils, basophils, and mast cells, and they are found to promote the chemotaxis. Okay, chemotaxis. So they are play their role in the inflammation. So antagonist of these receptors is developed for treating the inflammation, for treating the allergic conditions, inflammations, particularly in asthma, bronchial asthma. So the histamine serves as the mediator of the inflammation, and it is a type 1 hypersensitivity, immediate type of hypersensitivity reaction. And coming to the drugs of the histamine compounds, we have betahistine is an histamine analog. Oral histamine analog used to control vertigo in Meniere's disease. So in the Meniere's disease, in ENT cases, they will have vertigo. To control that, we are giving betahistine. Betahistine, okay, to control the vertigo. And some other basic drugs, okay, basic drugs like tuberculin, like morphine, like atropine, vancomycin, polymyxin B, they also stimulate your histamine release. That's why we'll get vancomycin, we'll get red man reaction because of if you give fast IV injection, you will get histamine release all over the body, and the whole body will become red. So it is called red man syndrome. So in such cases, the vancomycin should be given slow IV, particularly in infusion, not as bolus. So the drugs which are causing the release of histamine release is called tuberculin. It's a skeletal muscle relaxant, morphine, opioid, atropine, anticholinergic, and vancomycin. It's an glycopeptide antibiotic, the cell wall inhibitor used in MRSA infection, and polymyxin B. It's a broad spectrum gram positive. Only for gram positive resistant cases, we are giving polymyxin B. It is available in the form of topical ointment and for gram positive infections, and is not used intravenously because of potential nephrotoxic side effects. And coming to the histamine receptors, where I'm going to discuss about the histamine receptors. First one, H1 receptors, it mediates allergy, inflammation, bronchoconstriction, it promotes wakefulness. Okay, we know that it causes allergy, we know that it causes inflammation, we know that it causes bronchoconstriction, we know that it causes wakefulness. Agonist, we just see that we have betahistine used in vertigo, particularly in Meniere's disease. And antagonist, we have cetrizine, promethazine, they are all used in allergies, allergy conditions. And H2, we know that it stimulates your gastric acid secretions, and we have antagonists like ranitidine, famotidine, roxatidine, loxatidine. And they are useful in dyspepsia, particularly in acid peptic disease. And H3 receptors is pre-synaptic, inhibit the release of the histamine, and inverse agonist increase the release of the histamine. It will promote the wakefulness. So it is used in narcolepsy. We have the compound tiprolisant, and pitolisant. And H4 receptors, it is present on the inflammatory cells, eosinophils, basophils, and mast cells, and it promotes the chemotaxis. So coming to the compounds, antihistamines, H1 antagonist, that is called antihistamines. Antagonists at H1 receptors. There we have two generation compounds, first generation compounds and second generation compounds. First generation compounds have the CNS penetration properties. They will cross the blood-brain barrier, and they also have anticholinergic properties. So they can cause sedation and side effect. And first generation antihistamines, we have, they will penetrate the blood-brain barrier. They can cause sedation and psychomotor impairment. So it should be contraindicated the patients requiring constant attention, like your truck drivers, machinery operators, swimmers. You should not give to the such patients. And another property of the first generation compound is presence of anticholinergic activity. This property is responsible for wide spectrum use of uses, and it also causes more adverse effects also than second generation compounds. So highly sedating drugs, we have what diphenhydramine, dimenhydrinate, promethazine, hydroxyzine, and doxepin. We repeat it again: diphenhydramine, dimenhydrinate, promethazine, hydroxyzine, doxepin. Moderately sedating drugs of first generation compounds, we have phenidramine, cyproheptadine, meclizine, buclizine, celerizine. And okay, mildly sedating drugs, we have chlorpheniramine, we have mepyramine, we have cyclizine, we have clemastine. I will repeat the drugs once again. Highly sedating drugs, diphenhydramine, dimenhydrinate, promethazine, hydroxyzine, doxepin. And moderately sedating drugs, we have phenyramine, cyproheptadine, meclizine, buclizine, celerizine. And mildly sedating drugs, we have chlorpheniramine, mepyramine, cyclizine, clemastine. So three C's are here: chlorpheniramine, cyclizine, clemastine, and mepyramine. So what are the uses of antihistamines? They are useful in allergic conditions like itching, urticaria, hay fever, insect bite, IV poisoning, all kinds of allergies it is used. So itching, urticaria, hay fever, insect bite, IV poisoning. And to prevent the adverse effects due to histamine releases like vancomycin, atropine. So based on the anticholinergic properties, what are its uses? It is used in common cold to control rhinorrhea because anticholinergics will decrease your secretions. As in prophylactic agents in case of motion sickness, we are using promethazine, okay, and scopolamine, hyoscine. They will reduce your vomiting by decreasing your histamine. And we are using an Parkinsonism, drug-induced Parkinsonism. We are using promethazine, and also promethazine is also useful in psychiatric side effects of the drugs, acute muscular dystonia. When the dopamine is so much blocked, the cholinergic activity will be more. So you have to give anticholinergic drugs in such cases. So other use of antihistamines are they are useful in idiopathic pruritus. Cetirizine is also useful in vertigo. Okay, cetirizine is particularly useful in vertigo. So major side effects are sedation, psychomotor impairment, and anticholinergic side effects. We have dryness of mouth, blood vision because of mydriasis, and urinary retention and constipation. In second generation drugs, they have little sinus penetration. They do not cause sedation and they do not possess anticholinergic activity. These are the advantages comparing to the first generation drugs. Second generation drugs, they do not penetrate the sinus, so they will cause less sedation, and they do not possess anticholinergic activity, so they will not cause anticholinergic side effects. So we have the drugs like cetrizine and acetylestine. They have additional anti-allergic mechanisms. These drugs lack sedation, so they can be used safely in the drugs. Truck drivers and anticholinergic effects are not there. So their use is only restricted to the anti-allergic effects. It cannot be used in other conditions. If you talk about the compounds like terfenadine, they are the fastest acting antihistamine drug, but they are banned now because of it prolongs the QT interval by blocking the delayed rectifier potassium channels and can cause polymorphic ventricular tachycardia. That is called torsades pontis. And particularly, these drugs should not be combined with your enzyme inhibitors like ketoconazole, erythromycin, clarithromycin, and itraconazole. They can increase the risk of arrhythmia. And terfenadine is metabolized to an active metabolite called fexofenadine. So it is available as separate drug, but it lacks your potassium channel blocking property. So the fexofenadine will not cause prolongation of the QT interval or torsades partis. So it is safe to use. And astimizole is also like your terfenadine. It also is slowest and longest acting agent. It possesses arrhythmogenic properties similar to terfenadine. So it should not be combined or administered with ketoconazole, clarithromycin, erythromycin, and itraconazole. So what are the drugs which causes increase in the QT interval? Terfenadine and astimizole. And we have loratadine, desloratadine. Loratadine, since the name starts with L, it is the longest acting second generation antihistamine, and it is metabolized to desloratadine. It is available as separate drug. And cetrizine is your active metabolite of first generation antihistamine hydroxyzine. Okay, hydroxyzine is a first generation, and its active metabolite cetrizine is second generation. And all of your second generation antihistamines are metabolized to your active products, except the cetrizine and misolastine. They does not have active metabolites. So CM, remember CM, chief minister, cetrizine and misolastine does not have active metabolites. And cetrizine, it has additional anti-allergic mechanism because it inhibits the release of cytotoxic mediators from the platelets, and it causes inhibition of your chemotaxis. So cetrizine has additional mechanisms, additional anti-allergic mechanism. It can inhibition of your chemotaxis, so it inhibit your inflammatory factors, and it can also cause inhibition of the release of cytotoxic mediators from the platelets. And some people reported to have acquired sedative effects with the cetrizine. And coming to the levocetirizine, levocetirizine is more L isomer of cetrizine. It is more potent and less sedative comparing to your cetrizine, so it is much safer. And acetylastine, it has the most maximum topical activity, so it can be given as a nasal spray for your allergic rhinitis. Acetylastine is given for allergic rhinitis as a nasal spray. Other compounds are bisolastin, ebastin, levocabastin, rupatadine, acrivastin, olapatadine. They are also other second generation antihistaminic drugs. And olapatadine, it is also used in seasonal allergic rhinitis as nasal spray. And alcaftadine is available as ophthalmic solution for your allergic conjunctivitis, particularly in eye. Alcaftadine is useful in eye. Allergic conjunctivitis in eye, ophthalmic solution. And doxepin is a most potent H1 blocking agent. It is actually a tricyclic antidepressant, and now it also has more potent H1 blocking effects, 800 times more potent than your diphenhydramine. So this will finish your histamine, and maybe next class we'll talk about the serotonin. Thank you so much.